Welcome to lecture on early range of motion, gait training, and weight bearing guidelines. I am Major Arun. In this session, we will explore evidence based rehabilitation strategies designed to optimize early recovery after knee surgery. Our focus is on strike a balance, protecting healing tissues while restoring motion and gait in a safe and effective manner. By the end of this lecture, you will understand the physiological rationale behind early motion, gait retraining, and weight bearing progression. You will be able to identify key milestones that mark safe advancement across the different phases of recovery. We will also learn how to apply evidence based progression criteria so our decisions are not purely time based but guided by clinical findings. Finally, you will know how to evaluate outcomes using both clinical science and functional performance measures. The goals of early rehabilitation are clear. We aim to prevent arthrophyrosis, stiffness, and venous thrombosis, all common complications when movement is delayed. At the same time, we must protect the graft and fixation while reactivating quadriceps and hamstring function. Controlled motion is not just flexibility, it promotes circulation, synovial nutrition, and tissue healing. And perhaps most importantly, restoring full knee function and definitely the extension part of the knee range of motion early is essential for symmetrical gait and proprioceptive recovery. The range of motion must begin within the first 24 hours to 48 hours postoperatively, with the top priority being full extension. In the first week, we aim for 0-degree extension and up to 90 degree of knee flexion. By week 2, this should progress 110 degrees to 120 degrees, and by the week 3, the goal to achieve up to 130 degree of flexion while maintaining full extension throughout. These targets are not rigid deadlines, but clinical guidelines that ensure safe and progressive loading of the joint. To achieve these motion goals, we rely on specific strategies. Heel slides and wall slides are effective for gradually increasing knee flexion. Prone hangs and dedicated extension strategies or exercises help restore terminal extension. Patellar mobilization is introduced in early to prevent adhesions around the patellofemoral joint, and also it enhances healing around the joint and it prevents early onset of anterior knee pain post ACLR patients. We use passive or active range of motion but avoid aggressive forced flexion during rehabilitation procedures, which risk stressing the repair. Open chain kinetic extension is permitted only in a safe arc between 90 to 45 degrees to minimize gap strain. The heel slide is performed in supine position as well as in sitting position, with the patient slowly bending the knee by sliding the heel along the surface of the bed or floor. The trunk remains neutral and hip external rotation should be avoided. The exercise is crucial for restoring early knee flexion range, preventing capsular stiffness, and facilitating synovial fluid movement. Clinically, it allows gentle recruitment of hamstrings while minimizing anterior shear on the graft. Ensure movement are slow, pain-free, and the patient does not compensate by lifting the hip. In passive range of motion exercises, the knee is moved gently with external resistance, either from the physical therapist or using the contralateral leg. The aim is to restore motion without active quadriceps or hamstring engagement, thereby reducing stress on the healing graft. This intervention is particularly important in the first few weeks to maintain joint nutrition, prevent adhesions, and avoid arthrofibrosis. The physical therapist must monitor and feel carefully and avoid excessive hyperextension or forced flexion. Active assisted range of motion exercises involve partial patient effort supported by external assistance such as stick, strap, or the opposite limb. For example, in this video, the patient can use his upper limbs to gently pull the ankle towards the flexion. This gradual transition control from therapist to patient building neuromuscular awareness while continuing to preserve joint mobility. Clinically, it encourages muscle re-education without overloading the graft. The key is to assist movement rather than force it. Prone hangs are performed with the patient lying face down on bed, with the lower leg hanging freely off the edge. Gravity assists in gradually restoring full extension of the knee. This exercise specifically targets loss of terminal extension, a common limitation after ACL reconstruction. Achieving full extension is critical to normalize gait and prevent long-term quadriceps weakness. The clinician should ensure gradual exposure and avoid pain-provoked positioning. Restoring a normal gait pattern is a central goal of early rehabilitation. We achieve this through progressive use of assistive device, gradually reducing support as control returns. The emphasis is on symmetrical step length and ensuring full knee extension at heel strike. This prevents the quad avoidance or quadriceps avoidance gait during normal walking or running gaits. We must also identify and correct compensations such as pelvic drop or trunk lean before they become ingrained motor patterns. In the first 1 to 3 days, patients typically ambulate with a walker or bilateral crutches for safety. Transition to a single crutch or cane is only considered once full passive extension is achieved, and there is no extension lag during the straight leg rest, which usually occurs around first or second week in isolated ACL reconstruction. However, if there has been a meniscal repair or a chondral procedure, progression must be delayed according to the surgeon's protocol. The usual progression pathway is from walker or crutches to a cane and finally to a unaided walking. To define gait quality, we use multiple strategies. Verbal cueing reinforces heel toe patterning, straight knee at heel strike, and cadence control. Treadmill walking, a slight incline encourages terminal extension and promotes symmetry. Visual feedback using a mirror or a video, combined with rhythmic cues from a metronome, accelerates motor learning. Once the pain and swelling are stable, surface variability such as balance pads or uneven geranes can be introduced to enhance proprioception. In the early stages, gait retraining begins with double crutches. The patient is instructed to maintain upright trunk posture, encourage core, and achieve symmetrical step length. The emphasis is on partial weight bearing as tolerated, with equal load sharing across both the limbs. Clinically, this stage prevents compensatory gait patterns and protects the graft while re-establishing early ambulation confidence. Cueing for heel strike and avoidance of hip hiking is essential. As the patient progresses, support is reduced to a single stick or cane, usually held in the contralateral hand. This encourages near normal gait mechanics while still offering external stability. The goal is to facilitate reciprocal arm leg coordination and gradually increase confidence in the reconstructed limb. Clinicians should monitor for limping, over reliance on the stick, and ensure smooth transition toward independent gait. Once strength and control improve, the patient transitions to normal walking first with a functional brace, then eventually without it. This phase emphasizes symmetrical stride, proper knee extension during stance, and avoidance of compensatory trunk lean. The brace initially offers proprioceptive feedback and psychological support, but ultimate independence is critical. Careful observation ensures that faulty mechanics such as toe walking or reduced step length are corrected before discontinuing external support. Normal walk in front of mirror. Walking in front of mirror provides real-time visual feedback, allowing patients to recognize and correct symmetry in stride, weight shift, and posture. This simple yet powerful tool improves motor learning and reinforces proper gait mechanics. Clinically, it helps to eliminate subtle deviations that may predispose to long term dysfunction or re injury. Encourage slow, deliberate practice initially, progress into natural walking cadence. To refine gait quality, we use multiple strategies. Verbal cueing, reinforce, heel toe patterning, straight knee at heel strike, and cadence control. Treadmill walking with slight incline encourages terminal extension and promotes symmetry. Visual feedback using mirror or video combined with rhythmic cues from a metronome accelerates motor learning. Once pain and swelling are stable, surface variability such as balance pads or uneven terrains can be introduced to enhance proprioception. Biology. Axial loading promotes synovial fluid movement, which nourishes cartilage. It also enhances proprioceptive feedback and encourages muscle coactivation patterns that stabilizes the knee joint. But precautions are essential. Avoid deep squats beyond 90 degrees and positions where the knee travels far beyond the toes in the early stages, as these create excessive anterior shear forces on the graft. In isolated ACL reconstruction, weight bearing as tolerated is allowed from the D1, provided an assistive device is used for stability. Research shows that early weight bearing does not compromise gap integrity or increases laxity, provided progression is guided by criteria rather than time alone. When meniscal repair or cartilage procedures are involved, always follow surgeon's restrictions. Above all, monitor for swelling and gait quality. If effusion rebounds after activity, reduce the load and reassess. The progression follows a clear sequence. There is no hurry for walking or running. Immediately after surgery, begin with weight bearing as tolerated using crutches. As strength and control improves, progress to full weight bearing with crutch or walker. Once gait symmetry is restored and quadriceps control is reliable, the patient can walk without aids. The final milestone is a normal, base free gait with equal step length and proper knee extension. Aqua walking is a highly effective way to reintroduce weight bearing. Performed in chest or waist deep water, buoyancy reduces joint load while still allowing near normal walking mechanics. Patient begins with forward walking, progress to sideways and backward walking, and eventually increase the speed and resistance as tolerated. This environment builds confidence, restores symmetrical gait, and reduces impact on healing tissues. Clinically, it serves as a bridge between supported land based walking and unrestricted sport specific drills. Caution should be taken with water temperature and pool entry to avoid slips. Throughout the rehabilitation, we must remain alert to red flags. Failure to regain full extension by 2 weeks or progressive loss of flexion points to early arthrofibrosis. Rebound effusion after activity or night pain may indicate overload or intra-articular pathology. If painful, weight bearing persists beyond 2 to 3 weeks despite modifications, infection, hardware issues, or repair failure must be considered. Persistent Trendelenburg or stiff knee gait after device removal highlights unresolved neuromuscular deficits that require targeted interventions. Patient education is pivotal for successful outcomes. We provide simple home exercise programs with clear safety checks and symptoms tracking. We reinforce the importance of icing, compression, elevation, and wound care. We warn against overloading weight bearing or forcing flexion as this can compromise healing. Finally, we emphasize the role of adequate sleep, good quality nutrition, and adherence to surgeon's restrictions, especially when additional procedures have been performed. The evidence supporting these guidelines comes from the both consensus recommendations and high quality clinical studies. Key resources include the Aspeta ACL Rehabilitation Guidelines, Shia and Plex evidence based reviews, and biomechanical analysis of ACL strain during different loading conditions. In practice, always integrate surgical instructions, objective criteria, and patient specific factors into your plan. For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm up and concluding with an appropriate cool down. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.